Good morning or good afternoon, everybody. Thank you for joining us in today's webinar, The Power of Co-Creating Interventions for Chronic Conditions in Low and Middle Income Countries. My name is Maria Pesantes, and I will be the moderator today. We would appreciate if you could answer the question that will appear on the pop-up window on your screen. We will start in a few minutes. Thank you. We will be sharing the results briefly as soon as everybody is done. Okay, so before we begin, we would like to review some important points regarding data sharing. By participating in this webinar, you are consenting to the recording. Sorry, here you can see the results of the poll. Okay, great to see such diversity of people from different parts of the world. Okay, so now I want to tell you that before we begin, we would like to review some important points regarding data sharing. By participating in this webinar, you are consenting to the recording of this session and agreeing to the sharing of the event recording on our social media platforms. Additionally, any data shared, including questions and insight, will be used responsibly for education and collaborative purposes related to this session. We also kindly ask you that everyone respects confidentiality, especially regarding any personal or sensitive information that might be shared during the event. Our goal is to create an open dialogue in a supportive and secure space. Thank you for your cooperation in making this a respectful and valuable experience for all. And I also want to remind you to please do not turn off your cameras during the event. Okay, so with this said, I can now officially welcome you to the webinar, The Power of Co-Creating Interventions for Chronic Conditions in Low and Middle Income Countries. This webinar is organized by the COHESION-I project. This is a research collaboration from the Global South between institutions from India, Mozambique, Nepal, and Peru, aiming to improve patient satisfaction and health system responsiveness for the management of chronic conditions. This project is funded by the United Kingdom National Institute for Health and Care Research, NIHR. We're really very excited to facilitate this conversation on co-creating and co-designing health interventions. We thank all of our guest panelists and the participants for joining us today. Our three panelists will briefly share with us their experiences working with different stakeholders in Latin America, Africa, and South Asia. After their presentations, we will have an open discussion for which we appreciate you using the chat for comments and questions. We'll consolidate all the questions from the participants as they are submitted and address them during the discussion. Now, I am going to welcome the first panelist who will give us more insights about the project COHESION-I. Mariela Bazan is a Peruvian social psychologist with diverse experience working in education, health, and development projects in Peru. Most of her work has been with indigenous and rural communities in this country. She's affiliated with Crónicas Center of Excellence in Chronic Conditions and is leading the COHESION-I co-design process, and she's going to share that today. Mariela will be briefly presenting to you some of the activities she has conducted. Welcome, Mariela.
Well, thank you very much, Maria Amalia, and thanks very much for the opportunity to present the cohesion experience co-designing interventions. So next one, please. The cohesion project addresses the double burden of non-communicable disease like hypertension and diabetes, and neglected tropical disease like leprosy or neurocystic sarcosis. The chronic effects of this disease remain as an extraordinarily big challenge for our health system, especially for the low and middle income countries. That is why, recognizing this challenge, um, Chronicas, together with different research institutions and the Swiss funds, developed a first stage of the cohesion project that was between 2016 and 2020, working formative studies and a co-creation process in three countries, Mozambique, Nepal, and Peru. Next one, please. So now we are developing the second stage of the cohesion project that runs from 2022 to 2026 and has the aim to improve patient satisfaction and the health system responsiveness for persons living with chronic conditions, especially hypertension, diabetes, and one of the neglected tropical disease, focusing on the primary health care services. In this stage two, we want to achieve this ambitious goal, developing two components. The first one wants to implement and to evaluate a co-created and a co-designed intervention in the three countries, Mozambique, Nepal, and Peru. And the second component seeks to explore the possibilities to translate the experience and lessons learned in stage one of the cohesion project to other contexts. In this case, we are working in India. Next one, please. The intervention that we are co-designing have three components. There is the community component, where we are developing a communication strategy through audios, message, videos, posters, or the involvement of different community actors like champions or volunteers. The second component is the healthcare worker, where the three countries we are developing a training program for health providers. And finally, there is a health facility component that include a small fund around $300 that the community, together with the healthcare workers, have decided how to use it. So, for example, some facilities may purchase glucometers or blood pressure monitor, while others might invest in water tank. So these are the components and possible outputs that we have been developing through co-design. Next, please. So now this is the co-design methodology that we have been using, consisting in 6 steps. The first step, we select the intervention sites. The second step, we coordinate with national, regional, local health authorities, as well as territorial authorities like local municipality and, of course, community leaders. Having their approval, the output of this was a community mapping of each site. Then the third step, that is one of the crucial moments of our process, we conduct stakeholders interviews and workshops with healthcare workers and community members like leaders, patients, caregivers to confirm or redefine the interventions co-created in 2018 in the stage one. And also we collect data, very interesting, to understand the level of knowledge, their belief, their barrier or difficulties in the health services, especially in the management of chronic disease. So with all this information, we arrive to the step 4 of this process. Here we develop the contents and design all the intervention material, including the definition of key message per, per material, colors, characters, and supplementary resources, normally with specialists in these fields. Um, then, having all this, we went to the step 5. Uh, Here we validate the preliminary outputs through focus groups, community meetings, and interviews with users, where we present the materials, the audio contents, or the capacity building training to the target audience. And we, of course, gather all that information, all that feedback um, related to on appeal, the clarity, the message effectiveness, and the cultural appropriateness of the material. We also collect data very useful for the implementation, such as the radio station preference of the people, training schedule, and types of healthcare worker involvement. So with all that, we arrive to the last step, that is step 6. Here we incorporate all the feedbacks and we finalize the output, preparing them for full implementation. So these are all the process that we are following. Next, please. I wanted to finish this presentation. Remember some of the main challenge and lessons learned. Each country have encountered unique challenge, but I will mention the main ones. So one of the first challenge is the participant characteristic or their profile. For example, chronic patients are often older and may experience disabilities affecting their hearing or their vision. Um, and also rural or peri-urban settlements participants tend to have lower literacy levels. Therefore, we adapt our workshops, tools, and resources to facilitate inclusive participation. We also address power imbalance by dividing participants into smaller groups, encouraging an open communication. A second challenge is managing the participant expectations. As you know, the community have enormous needs. So that is why we consistently clarify the project scopes and the limitations to minimize potential frustrations or disappointments. The third challenge are the geographical and weather conditions. We have different countries with rainy seasons, a flood in one of the Mozambique sites that requires the site relocation, and the road complexities of rural Andean communities in Peru are important examples of this challenge. A fourth challenge is the political instability of our countries. For example, Mozambique is facing a complex political landscape due to upcoming elections, and Nepal recent change in authorities requires rebriefing new officials. The last challenge that I want to mention is that we have to complement the expertise of our team members with external specialists in other areas, for example, in communication, to be able to develop the intervention component in each country. So before closing, I want to highlight that our co-design process has not finished, and of course, other challenges might arrive. Until here, I finish with my presentation. Thanks very much for your attention.
Thank you very much, Mariela, for such an interesting presentation with so many details, and I know you have more. So before we move to our next panelist, we would like to know a little bit about our participants' experience with either co-design or co-creation. For that, there's another poll, and we will want to ask you to answer the following questions. Have you been involved in co-creation or co-design processes? This will also come as a pop-up window. And we will wait to see the results in our screens. Please, let's stop the poll now. Thank you. You can see that most people have had some level of experience. Okay, so Mariela shared co-creation experiences within a research context. However, the principles of co-creation are also crucial in more applied fields in global health, development, and humanitarian contexts, which we're going to explore now. It is my pleasure to introduce our second panelist, Dr. Michael Odong. He has over 20 years of experience in public health, social behavior change, and community engagement. He has done extensive work in humanitarian and development initiatives across Africa and Asia. Currently, Michael works as a global technical advisor for Sight Savers Uganda, where he integrates social and behavior change strategies to address neglected tropical diseases. Welcome, Michael.
Thank you. So I welcome everyone to my presentation. I'm going to take you through some of the piece of work that we do at Sight Savers. Briefly, Sight Savers is a global organization. It's a charity organization with headquarters in the UK. We are in over 30 countries, and most of our areas of focus in neglected tropical diseases and high health and many other areas, including education. But today I want to take you briefly through the collaborative development of social behavior change interventions for lymphatic filariasis management in Guinea-Bissau. So next slide, please. So lymphatic filariasis is a parasitic infection that affects the lymph nodes, lymphatic systems, and it is transmitted by infected mosquitoes and always present with swollen limbs, swollen genitals for men. And in Guinea-Bissau, we have over 1.2 million people who are at risk of lymphatic filariasis infection. And efforts to eliminate this primary driven by mass drug distributions, administration, which is cover over 50%. And basically mass drug administration is aimed at disrupting transmission and reducing on the parasite loads in the body. And over the years, as most countries are transitioning toward the eliminations, we see a shift from mass drug administration to more of patient care services, disease management, and disability inclusion. And when I talk about disability inclusion and patient care services, we talk about medical treatment of lymphatic filariasis, prevention and self-care, self-management of disability, and promoting mental well-being and reduction of stigma. So all those aspects comes in handy, and that's where social behavior change becomes very crucial. So that shift away from the mass drug administration to DMDI is where social behavior change is very critical. We use social behavior change to address stigma and promote positive self-care behaviors among patients. And some of the key behaviors include limbs washing, skin care, exercise, and elevating limb elevation, some of the practices that would really promote them at home. Next slide, please. So coming back to the aspect of the co-creation processes, we go through a number of steps. And of course, it starts with the actual investigation with we need data to inform the processes that we go through. So the investigation basically starts with understanding community need, context sets, assets and stakeholders that are involved that should be engaged, and that follows by focusing those aspects in terms of what are the behaviors that we want to promote and what are the resources that we need, what are the key insights that we need to prioritize based on the particular data that we have, and what are the barriers and facilitators that should inform our strategy. So all those initial processes basically helps to refine the insights and informs the directions of the social behavior change intervention. And it's done collaboratively with the stakeholders at different levels, at the community level, at the household level, at the national level. So after refining the insights and you're clear of the behavior to address, we have what we call the co-creation workshop. You remember all the process started collaborative. All those data collection has been collaborative process. So the data, the design, the co-creation design now bring in the diverse participants that come together in a room and co-create the strategy, interventions, think through and share experience of what has worked and what they think can work in their context. And that's where the diversity of participants become very important. So when you look at it in terms of the ranges of categories of participants, for this case, the lymphatic filariasis patients and their caregivers, those are critical people who can tell you information about what goes around people who are affected by lymphatic filariasis in their homes. Healthcare providers at the point of care, faith-based and cultural leaders, to bring the cultural perspective and faith-based kind of perspective that may influence the behavior around the disease. Traditional healers, Ministry of Health officials at the national level. So you you realize the number of indicated 30 in maximum based on practice that we, assuming I'm facilitating a co-creation workshop, and I'm the facilitator without any assistance, then I need to look at the number that is manageable. So the 30 is not that, that is not that a number that's the concrete that should be 30. Basically, 30 is the number that is manageable. In that case, if I'm to have a group of people working in a group of four, four groups of seven, average of 7 to 8 people, then the 30 would actually be easy. As a facilitator, it's easier to coordinate those different groups. And that's why the numbers of the group matters a lot. So the group collaboration in that process of collaborating and discussing and exploring what are potential strategies and barriers, the data collection process still continues even after that point, because whatever you collected earlier, you use that forum as an opportunity to validate previous information, at the same time collect new data. As much as you're now thinking about solutions or interventions, they are emerging new information that you still incorporate. So it's a process that is continuous and require actually skill from the facilitators to be able to navigate through all those group maps and issues or insights that emerge from the different groups. Of course, there are key principles that the co-creation that we do are data-driven, inclusive. We ensure we involve a diverse group of people, amplify voices of marginalized people, and of course, it is a participatory process throughout. Next slide, please. So in terms of the methods, at the data collection level, participatory methods that we use that include engaging community members as co-researchers, to identifying barriers and facilitators' behaviors, and engaging community members in the focus group discussion that encourages open dialogues, and of course holding regular meetings with community leaders and conducting transit work sometime if you are just supposed to look, observe certain behavior at the community level, and of course participation and action-oriented planning. One comment that I need to make on these methodologies that these are not rigid methodologies. You adopt what suits the particular context. You realize that you may not actually need to apply all of this. You may have information already and you start your co-designing from a certain point. So these are some of the different methods that we use, but they may vary according to context. There are many challenges when we talk about co-creating interventions. One is the limitation in information and knowledge regarding lymphatic filariasis, disease management, disability inclusion. This sounds most community across Africa knows lymphatic filariasis as they know the treatment from the perspective of multi-drug administration. So when you talk about disease management and disability inclusion, it sounds to most people as an area which is new to them. And that becomes a challenge. In terms of information that people give you, it becomes very difficult. And that also require a lot of effort to carefully select who should participate in the co-creation for you to have a meaningful discussion. And of course, there are cultural belief, misconceptions, and myths around lymphatic filariasis. I'm very shocked in some communities that I've interacted with. We see it as a disease, but in some community, they see it as a pride. In one community where I worked, they said, if you're a man who is supposed to talk, if you're a man with a hydrocell in the community and he talks, people respect him because he has hydrocell. So we are looking at it as a disease, but it's a pride to some people, and people respect people have high self. So those are some of the challenges that you come in to address the issue. Probably you kind of, it's an uphill task for you to kind of shift people's mindset from to most men, potentially you're trying to remove their powers or their position in the community. So those are really serious challenges when it comes to addressing some of these issues. And of course, we work with the National Ministry of Health across African countries. And when you talk about co-creation, it's very challenging. Just people think it takes a lot of time. We need to sit in one place as experts and we develop this intervention and implement it. Why do we need to go through all these processes of testing and retesting and testing intervention? Why not just go straight and implement it? So those are challenges that you get confronted with. A lot of questions that people ask you, why are you wasting all this money to have all these workshops to keep talking about one thing when we know this thing, we have been doing it all these years. So that becomes one of the biggest challenge. And because, of course, in terms of what works, there are wide range of participants. And like I said before, careful selection of who should participate. And of course, looking at wide range could be looking at the continuum of care. Who has who are the key stakeholders in that process? Who are the influential people that may have, in one way or the other, influenced the lives of people with lymphatic filariasis? So careful selection of those key stakeholders to participate in the co-creation is one of the key determinants to have a successful co-creation. Application of, I know there are many tools that we use during the co-creation, but I've seen empathy mapping really tool help to visualize user behavior and emotion. And of course, there are multiple tools that you can apply. Them depends on the disease, the condition, the context, the kind of people you're engaging. Utilization of the mixed method for data collections. And this of course cuts across the traditional the data collection that we know, the focus group discussion, key informers interview. We are seeing people advancing into social listening because of the advancement in technology and social media. There are a lot of information, and also looking at this condition is a condition that most people take it as a secret. So they may not be willing to openly talk about it. So having a kind of a careful data collection may help you get deeper into more critical insights. Data validation in the process, and I've used this a lot, that every single step of the co-creation is an opportunity for validating your data. So you keep validating. If I collected data from the key informants and I'm going to do a focus group discussion, the question I ask myself, am I still hearing the same thing coming? If I go into the co-creation workshop, I ask myself, are things that are coming out from the co-creation similar to the things that are already collected from other sources of information? So that continuous validation of data as you go along helps you to have a final and a finer insight that guides your strategy. Next slide, please. Okay, so briefly, I'll talk about the issue of gender, disability, and cultural perspective. Across board, across Africa, challenges of men seeking poor health-seeking behavior among men, and including myself. Care provision is typically perceived as the role of women, and in this case, if I have a lymphedema or hydrocele, I may, and I don't have someone or a wife to take care of me, then I'm unlikely going to follow any instruction I'm given as a part of the DM and DI. On the issue of disability, lymphedema is viewed as a disease rather than disability in most communities. And of course, most programs and partners, there is a lack of sensitivity, disability sensitivity programs that could provide opportunity for integrating social support. In most cases, they're not available in most country and community. And of course, availability of assistive devices for mobility, especially for people who have lymphedema, is a bit of a challenge. Culturally, traditional beliefs and practices include witchcraft and evil spirit that are very strong in most communities when you talk about lymphatic filariasis. And self-stigma is more common among people who have the conditions. And traditional healers and community support play a vital role. And in most cases, in most of our co-creation, we ensure we prioritize those key stakeholders to be part of the discussion. Thank you very much.
Thank you, Michael. Thank you so much for your presentation. Super interesting, especially the I'm just thinking about the skills that the people who are doing these different processes have to have, and the sensitivity to the local indigenous medical traditions, the cultural values and the understanding of disease. Thank you so much. So I want to remind our participants that we will have a Q&A session, so you can ask questions to all of our panelists. So please don't forget to send your questions through the chat. So Michael shared his experiences specifically in Africa from a specific disease in the context of international cooperation perspective. Now we're going to have Devaki, who will take us to Asia to provide us with a brief overview of her work in social participation. Dr. Devaki Nambiar is a program director at the George Institute for Global Health in India, with over 20 years of expertise in health policy and systems research. She focuses on equity, social inclusion, and community health. Dr. Nambiar advises WHO on health inequality monitoring, program orientation, and inclusive guideline development. She serves on prominent Lancet commissions, global boards, and advisory panels. Dr. Nambiar is a recipient of the Emerging Leader Award from the Royal Society for Tropical Medicine and Hygiene, so it's a pleasure to have you here. Thank you for joining us.
Thanks so much, Maria Amalia, and thanks to the Cohesion Group for inviting me to do this. You'll see my first reaction to the remit of what I'm supposed to present is gulp. I'm a health policy and systems researcher. I'm a social scientist. I don't actually do a lot of my own team leading intervention development. I look at health systems, right? But somehow the cohesion team was very inclusive and said, no, you still present. So with the main caveat that I will change the title. If we go to the next slide, I have, as a mischievous health policy and systems researcher, I have revised the title of what I will present. And it is on the power of co-creating not just interventions, but a platform for social participation, which is an area of my work. And this is the participation of minoritized groups. And it's not so much an intervention that we try to look at in our health systems work, it is health reform. So the intervention is health reform over a period of a very long time, as you can imagine. And the chronic condition that we are concerned with is health system failure and health system inequalities, right? Rather than a disease group. And I will explain that a little bit more, because disease-focused organizing and community action for health has actually been one of the drivers of health reform, a successful intervention, if you think about it. And I think I'll talk about that in the multiple contexts that our group works. But I also wanted to underscore, particularly in the current political context, that this chronic condition of health system failure and failure to prioritize health is not limited to LMICs. it also exists in high-income countries with wide-ranging effect within those countries and across the globe. So the remit, if you will, of the group whose work I'm presenting is therefore LMICs and high-income countries. Okay, and so the group whose work I'm presenting, I happen to serve on their secretariat, is SPHERE. It's the Social Participation for Health Engagement, Research, and Empowerment Group. I'm just posting our website here so you can learn more about this group. And one more thing is that these slides are also not only authored by me, they are co-designed. So I can share the blame if any of this is confusing with the others in my SPHERE group. So we'll move to the next slide. The Cohesion group asked us to sort of talk about the approaches used, talk about the methods used, the actors involved, and the lessons learned. Why then did I choose to talk about this social participation for health kind of platform? I feel it still has lessons for the type of work you may all be interested in, because it has this imperative or prerogative of linking the global to local. And quite often, when we are doing co-production or any intervention, testing and development for that matter, we are taking global lessons and bringing them to local contexts. So there is a sort of similarity, if you will, between what would happen at a single intervention level and our agenda of reform. But our field, of course, for reform is also at these multiple levels. So we're seeking not only to reform what's happening in country contexts with community voice in health reform processes, but we're also interested in multilateral fora. What are the global conversations about social participation, right? So we have this linkage of global to local. We were lucky to be able to work, this is my second point, we were lucky to be able to work with highly established civil society organizations who have a long track record of organizing communities, being recognized and partnering with government, and in some cases being represented in global fora, but in all cases having a lot to teach global fora about grassroots mobilization. Right. So in a sense, at the national level, they were already on the scene and had the absolutely critical local legitimacy. And I think in Michael's presentation and also in Mariella's, you see the significance of that local legitimacy and capacity, whether it's local leaders or members of communities or even implementers in those spaces. Right. So again, a similarity there. And finally, since we were interested in different population groups that are minoritized, so just to give you an illustration, the work is in Argentina, Vietnam, and Kenya. So not just Asia, sorry, Maria Amalia, and also in India, where we were interested in sort of the health and rights of trans persons, persons living with TB, and we were interested in the broader framing of universal health coverage reform. So then that actually comes into a broader kind of canvas, or for UHC, they call it an umbrella of reform. So it tends to not be disease focused. And quite often, I think, and again, Michael and Mariella also talked about this, often quite immediately, your framing of the issue is challenged as soon as you start a co-design process, right? And that can be very informative and very important. And so we sort of anticipating this created a kind of window of let's look at whatever the local priority is in systems reform. So we'll go to the next slide and I'll get into this a bit more. So one of our questions was who all was involved? I mentioned on my last slide that we had anchoring NGOs. So these NGOs know about global conversations about health reform and about social participation, but their legacy work, their core business is local action. And so they have this dual recognition and locus standi with communities and also with government. Critically, in almost all the groups we worked with, there were multiple generations of community members or affected persons or persons with lived experience or community organizers involved. And so SPHERE became a chance to kind of have an intergenerational transfer, documentation, and generation of knowledge. And I think being conscious of that has been a very powerful thing for us in our consortium. And that gets supplemented and assisted by academic institutions and expertise within countries, right? So because this is one of these multi-sited pieces of work, coming in as merely an external partner is often not viable. It doesn't make sense in the local context. So we have been lucky to be able to find partners that we can go back and forth with to move the work ahead. And that also has been multiple generations. So more seasoned folks with experience in social participation, other folks who are just joining the scene, which allows you to clarify and re-clarify why we are here, and also make sure that assumptions are checked, and that there are opportunities for varied types of inputs in a co-design process. The other thing we made sure we had is a core committee which had representation of all of these actors in it in the core governance structure. I'll talk about that on the next slide as well. And we as the George had the flexibility to be the secretariat for this group. And I think it's sometimes helpful to have the secretariat of this kind of multidisciplinary co-creation process be in an academic institution, because we're quite interested and have time to make protocols and focus on method and kind of try to keep that tempo as we would for a research project. So we felt that can sometimes over bureaucratize things, but in other ways it can be helpful and even challenge us as researchers to support a sort of research action agenda. And critically, perhaps among the most critical things is that we had a very agile and flexible funder, a philanthropic organization that said, we trust you. And quite often, many of us in our co-design and co-creation processes may not have that flexibility from the funder in terms of how we approach things. So this is a huge piece of what has been possible in Sphere. We'll go to the next slide and I'll explain a bit more. So what did we do? So we worked with, well, let me first explain the two little icons. So the one at the top is supposed to be a sofa, like a couch, okay, representing space. Okay, now I could have done a star for like outer space and whatever, but I chose a couch because a couch is comfortable. And my thought was, you need safe space. Okay, so it's very important for that safety piece to be in there and for people to be comfortable around each other, to disagree, to challenge, and so on. And so for us in Sphere, we have a lot of these like family style fights, right? About, I'm not sure that's the best way to, so that level of comfort is important. The second one is meant to reflect time. And this is one of those things, in English, it's called a metronome. And when people who play the piano may have seen this, it just goes tuck, 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 okay? So the idea here is that a lot of these things take time, but they also require like repetition and consistency, right? Like you have to keep going, keep coming back, keep a rhythm of your co-creation process to give it life and to give it motion. So those are the two metaphors that reflect the way we tried, not always succeeding, but the way we tried to do our work. So we started with orientation of CSO leaders, and it took a while to sort of explain this and to sort of even unlearn the way we usually do projects. And we had a very long process, an iterative contracting and work planning process where people changed their minds, people checked in community meetings and things were not feasible, and then we restructured, and then something went for regulatory review and it didn't go through, and then we started again, and so all of these kinds of things happened, as they do in collaborations. But we made sure we had, again, that metronome tick-tock of community consultations to prioritize scope. Sometimes that even changes, and then that's important. That's part of co-design. Working with local academic resources kept us honest and made sure that we had a grounded research process, including the creation of a baseline in many cases to just understand where we're starting and where the arc of change begins. Right? So that was really useful, as were research approaches that are a bit more novel, a bit more radical. And one of these is the witness seminar. And I really encourage you to learn more about this one, because it's one where really that intergenerational aspect of co-design came into play with our partners at Fundación Huésped. I'll show you a picture of this. And not only was this a research data generation exercise, but it was an advocacy and mobilization exercise for our partners. So it added a lot of value beyond what we were initially conceiving as well. So one of these is the witness seminar. I think a critical thing we have been able to do is have that financial, technical, and communication support for the CSO partners. And, that involves a fair bit of hand-holding and kind of supporting even very logistical kinds of things. Do people have the ability, the visa to travel abroad, for example? Are we making sure that if 2 or 3 or 4 people need to be there, they are? So ensuring that inclusion is hardwired into processes to the extent possible, not always possible to do in a minute, but as good as we can, making sure that people feel they have the technical knowledge. And again, my colleagues also spoke about this, that orientation, what is the sort of science side of what we're talking about, in an understandable way, in a way that it can be used. And similarly, it can be talked about and communicated about. And so finally, you'll see the last point is we wanted our CSO members to contribute to global webinars like this one, to be doing and leading capacity strengthening, to be at global fora. And that takes some preparation and that takes some just cheerleading on the sides. And we've been very keen to do that. Again, trying to link that global level to the local level. Sorry, I have a phantom hand happening. Anyway, we'll go to the next slide where I can explain a little bit more as I close out. So we wanted to talk about what this means for things like gender, inclusiveness, intersectionality, disability, and interculturality. I think for the Sphere project, to be able to decide what the Sphere is about has been key. So our partners were able to have a platform to decide what to prioritize. And they chose to work on, in Fundación, for example, the picture on the top left, on trans health and rights, carrying out a documentation exercise of movement building of one of Argentina's largest trans collectives. And this became a really moving and transformational advocacy milestone for them because they came together, constructed this history using a research method together, but then also having an intergenerational transfer of knowledge. That witness seminar now serves the purpose of academic analysis on social participation, but as much it serves as a foundation for mobilization and use by civil society partners. On the top right, you'll see Margaret Lubale, who was presenting at a World Health Assembly side event. Being able to tell one story in these global platforms has also been really important. To be able to see different, more diverse voices in these fora has been really key for us. And for people to be able to really make that strong connect between global and local. Sometimes even, and I'll be frank here, faking it till you make it. The work has only just started. We haven't done that much, but we're still going to talk about it because it raises accountability. We start to say we're going to do this, and then we have to, right? And then the other example is from the health systems research meeting in Nagasaki, making sure there are opportunities for co-learning, understanding these concepts, and being able to bring them home on your own terms. So that's been sort of the types of things we try to do. I'll show my last slide and then we can close. I just wanted to explain that some of our Indian delegates got to go to this absolutely transformational meeting last November at the Thai National Health Assembly. And I would just encourage you all, if you can score an invite, it's really great. This follows the passing of a World Health Assembly resolution on social participation for health. I'm pasting some of it here, whatever Zoom allows me to paste. Wait one sec. This is actually a World Health Assembly resolution that was passed calling for the institutionalization of social participation for health. And across regions, there is a growing movement to really build people's voices in the health reform space, whether for chronic conditions, or for other conditions, and the linkages for multimorbidities as part of UHC and the Sustainable Development Goals, and frankly beyond. So there really is some momentum growing on this. We hope to be unfettered by some of the setbacks that are already happening, but we're moving ahead and looking forward to learning together and having these kinds of assembly spaces to co-create. I'll end here. Thanks so much. Look forward to your
Thank you.
questions.
Thank you, Devaki, so much too, for taking us to the macro level and how, like bigger institutions can also get involved in using social participation, but for, changes in more, you know, changing the health system rather than just, what is happening at the community level. Thank you so much. So now we have several questions from the audience. So I'm just going to start with two of them, and let's see how it goes because they are so interesting. So the first two questions, and you can choose to start with either of them, is, if you can share with us, how did you measure the success of the co-creation or co-design process? What were some of the indicators that were telling you that things were going in the right direction? And the second question is, maybe you can combine them. What are some of the things that you might do differently in the future so that it can be like a lessons for other people in the audience? Thank you.
Okay, I'm going first. Okay, thanks. I just getting into the question of measurement. Yeah, based on my discussion, co-creation, there is no one shoe fits approach. It depends on the context, the target groups. But in terms of measurement, always look at validation in terms of you develop your intervention, be able to validate it with a certain group of people. In this case, we do validate with the Ministry of Health, other partners who are doing similar things, and also user feedback. User feedback in terms of pre-testing some of those interventions before you actually roll them out. And that helps you to basically measure whether you've done your intervention is actually acceptable, able to address people perceived it the same way. So those are some of the measurements that it helps you to guide you on the co-creation. The second part of the question is what would I do differently? From my experience, it's having one big co-creation always is a challenge. I talked about identifying diverse participants, and of late, I've learned and started practicing more small design group. A small design group is manageable, and you can sometimes be able even to work remotely over certain small tasks, and it does not require probably only one sitting that you be able to complete everything in that sitting. So you have multiple sitting, probably you go back and reflect on what you have discussed and help you to refine it again. And of course, the review of the number of days for the workshop. I've seen most participants are very productive in the first 2 days. So if we are going to do a workshop that's going to take more than 2 days, probably you need to prioritize to do the critical thing in the first 2 days, then leave the third day and the fourth day for some other thing that doesn't require much brain work. Yeah.
Thank you, Michael. I don't know, Mariela, if you want to complement Michael's perspective.
Well, the first question that was the how to measure co-creation and co-design. Well, in our case, in the Cohesion project, we are making a lot of evaluations. We are making a quantitative, a qualitative, a process and a economic evaluation. So especially the process evaluation and the economic evaluation, they will measure the impact of somehow of the co-design and the co-creation process. So yes, in our case, it's a good way to understand the impact of this process. And something that might be make difference. First, I think that we always need to prepare for all the different challenge that you can find in the field work. And always, I think that the main thing is how to manage the difference in the field work. No, so you have to be prepared, having all the alternatives that could be possible in the field work, and preparing for that, no. And also the time, no, the time always is you need always time for having more feedback of the people, but in some time you have to stop and to to say, okay, that is enough. You need to move to the other phase or stage, no. So uh, that evaluation of when to stop is also very important.
Thank you, Mariela.
Shall I quickly come in? I think one of the concurring with others, and this relates to the latest question Lita has asked. I think one of the markers of success is to be able to keep going. So the fact that there was a cohesion and now there is a cohesion-I, that is a mark of success, right? That means you are generating good science and you are remaining accountable to the communities that you're working with, right? So to be able to sustain in and of itself is a signal of success. I think another is really to be, and this can be documented in evaluations, is being able to make it through some of these humps. You know, when there is that pushback, when you run into a sort of challenge. And as Michael was saying, you know, it's a flexible methodology. How do you navigate that challenge? So being able to have process documentation of and to be able to achieve that is another marker of success. So these require, as my colleagues have said, mixed methods to document and to understand, and multi perspectives as well, right? Because we may be thinking with our CSOs that we're doing a brilliant job, but the state is just like, this is not feasible. Like, what are you doing? So to be able to engage constructively without wasting the time of state functionaries will also help reveal those areas of weakness and the areas of achievement. As for what we would do different, I think we had with Sphere great enthusiasm and voluntary labor coming in from all directions when we started off. And we very enthusiastically took this into our fray. And as more and more people got interested, we sort of added them to different workflows. And actually, that's a kind of difficult thing to navigate when you start a co-design or a co-creation process, because you know, there are different stages, and if you're bringing in more people, new people, they have to be oriented. Then there's maybe turnover, and some people leave, and some of that change occurs anyway. But if you have a lot of that, then your project starts to become a bit loose, you know, and the quality it takes longer, I should say, to achieve quality, because you're just reinforcing, reorienting, you know, those kinds of things. So I don't know if you can have an approach where, you know, this is the team and this is going to be the team for co-design, but having a little bit of maybe rigidity for some critical stages, just to make sure you can hold the work through. Otherwise, it just takes much longer. Yeah.
Yeah, thank you for the three panelists for for all these super relevant ways of understanding better the complexity of the process. I know that it's 9:02, so I'm going to ask everybody to stay please 5 more minutes, because once you exit there will be a poll that I want you to please answer. So I just want to wrap up saying thank you very much to Michael, to the Bakia, to Mariela, and to the COHESION-I, and all our partners for for organizing this event and for being here. This is the end of the today's webinar, The Power of Co-Creating Interventions for Chronic Conditions in Low and Middle Income Countries and from High Income Countries, and which was organized by the COHESION-I project. I want to remind everybody that as soon as the Zoom ends, you will have another poll that please I would like you to fill up, because that will allow us to continue improving and to make sure the next webinar is even better. No, so please don't forget to follow us on X and YouTube, and you can find us with the tagline at Cohesion Project. And thank you very much, everybody, for being here, for sharing your time, and for sharing all your incredible experiences. Thank you.